Dear colleagues, dear friends, ladies and gentlemen, thank you very much for being engaged with us in the EndoEngage program that we launched this year. Today is the fourth meeting that we have in 2025, and we are honored to have with us today Professor Tommaso Falcone from Cleveland Clinic, Ohio. Obviously, he doesn't need introduction, so I will not waste time. I will leave this difficult task to Pavel Basta, but I really am honored and very grateful for him to join us today. He's one of the pioneers in endometriosis management in the whole world. And in a way or another, I personally learned a lot from him. And in a way or another, we all benefited from his participation in the either research or surgical skills and the spread of knowledge and awareness, etc., in the field of endometriosis. I will not waste a lot of time. I can see that we have a number of colleagues today. I will pass quickly to Pavel Basta to introduce Professor Falcone and then to Alin. Please, Pavel.
Hello, dear colleagues, and I have a great pleasure as I've been introduced by Mohammed to introduce Professor Tommaso Falcone, who of course doesn't need an introduction, but just to be on the right side. Professor Falcone is now appointed as an executive vice president and president of Cleveland International Global and Emerging Markets. He is a professor of obstetrics, gynecology, and reproductive biology at the Cleveland Clinic Learning College of Medicine. He has graduated from McGill University in Montreal, where he did his residency. And then he was appointed as the chief of staff and chief academic officer and medical director at the Cleveland London Clinic between 2018 and 2022. He wrote a number of articles, more than 500, and book chapters. He's, as Mohammed said, one of the pioneers in reproductive medicine and minimally invasive gynecology, but also he is one of the pioneers in uterine transplantation. I have personally had the pleasure to meet Professor Falcone in 2018 at Cleveland Clinic while there was an international meeting on uterine transplantation. And we have just heard that in the UK, finally, the first baby was born from the female with uterine transplant. And I could continue for a long time, but we are very short with time, as we heard, only 30 minutes. That's why I stopped the introduction now and let the floor to Professor Falcone. Thank you very much.
Yes, just a moment. Alin, can you please present the short video that you have, and then we will go directly to Professor Falcone to
sure,
speak
absolutely.
about a very important topic, which is the fertility management in patients with deep endometriosis. This is a very hot topic and a big question mark that all our patients ask us, and we'll find no better than Professor Falcone to speak to us about it. Please, Alin.
Absolutely. So before we get going, we'd like to thank our sponsor who's supporting the EndoEngage sessions, Getting Richter, and please allow me to share with you a very short video.
What does it take to make a medicine? You need to shift your perspective to see success comes from a series of innovations. Without the dedicated work of our highly trained researchers, no such progress would be possible. It is today that experts need to think about the diseases of tomorrow, and premium quality requires the latest technology. All these aspects come together to create new treatments that will improve the health of millions. This is what we work for every day. Gideon Richter, health is our mission.
Thank you, Alin. Tommaso, the floor is yours, please.
Okay, let's see. It says sharing is not turned on. You can request presenter sharing. Okay.
Sure, just a sec. Yep, it should work now.
Okay, let's see. Okay, right here. second here. I have to change my screen here. Do you see it now?
Yes, Omazu, we can. We can see,
Okay.
please. Yes,
And you see the full screen version, right?
indeed, we can.
Okay. All right. So I'm going to talk about clinical management of patients with infertility and advanced endometriosis. My interest, I do both IVF and I do surgery. And so for me, it's part of my practice every day. I'm going to concentrate on a few things. Surgery on fertility outcome, potential complications, especially when you're counseling the patient, and the consequences of a non-operative approach. So the first thing that's important to remember is when I show you this, the real question is what kind of evidence? So when I was editor-in-chief of JMEG, Konix and Uzia, Zuppi, and Gomel, they said they wanted to submit this editorial saying that, and the editorial was about a double-blind randomized clinical trial in the journal. And they said, what's more important, the randomized clinical trial versus consensus of opinion? And so they said consensus of opinion is in fact more important than a randomized trial. So, however, back in 2013, when this group, Johnson and Lauren, when they published their consensus on the current management of endometriosis, the same group wrote a letter to the editor, and they said the title is misleading. An opinion paper is not a consensus paper. And the response from Johnson said it must be stated at the outset that there is no consensus in the literature as to what constitutes a consensus paper. So the point of this is that we're going to talk a little bit about consensus, but there is actually no opinion of what it is. So I'm going to define it as if you agree with me, then it's a consensus. And if you don't agree with me, then it's my opinion. That's what it boils down to. So what are we going to consider? Well, I want to consider the pregnancy outcome of surgery versus IVF. Will the surgery impact subsequent IVF? And what are the complications so that the patient can make a decision? And what are the concerns that she have? Okay, so I'm going to present two cases that I have seen recently. So this is a 24-year-old woman, severe chronic pain, stage 4 endo. She's had a history of STIs, shows bilateral endometriomas with the right ovary, as you see, measuring 5 centimeters, left ovary, as you see there, just diffuse wall thickening of the uterus, the anterior rectal wall, and as you see, her anti-Mullerian hormone is extremely low. So the question really is 0.02. And if you look, this is what you see on the MRI. So how would you like to manage these patients? And the second patient, as you see here, this is a separate patient that was sent for in vitro fertilization. And this patient, like I said, separate from the previous one, was in fact asymptomatic. She was doing her baseline for IVF. And as you see, she has this lesion on her right ovary, multi-loculated 7x5. And on the right side, it's huge. I didn't have a measurement. On the left side, sorry. So this patient then was sent for IVF, and the IVF doctor says, I can't access any of the follicles. Please treat her. So then she was sent to me for surgery, and this is what it looked like inside. Bilateral large endometriomas that they could not do IVF, which is what we usually do in these patients that are asymptomatic. So I presented two cases. The first one, patient not bad ovarian size, anti-Mullerian hormone as low as you can get almost, pain and cysts, but adaptable cysts. And this patient here was bilateral endometriomas, asymptomatic, but the IVF doctor, she's only interested in her fertility. IVF doctor says, I can't access this. How can you help me? So the first consideration in all these patients is if they have pain and the endometrioma, most likely the pain is coming from deep disease under the ovary. So the question is, what are we treating? What are we treating in this patient? The pain, the fertility, or access? Now, I have to tell you that I'm doing an operation tomorrow on a patient who has the same ovarian disease as this patient, not this patient, but the other, except she's post-liver transplant ×2. So she's had 2 liver transplants. First one failed, the next one, and she has bilateral endometriomas, and believe it or not, she's going to do IVF, but the cysts were as big as that. But again, she has no pain. So the mission of each of these patients is different. If the patient has pain, then and you want to treat the pain, you better treat other disease. If the patient is sent to you because they can't access the follicles, and especially for my patient tomorrow, who has two liver transplants, thrombocytopenia, and a low hemoglobin, I'm going to do the minimum amount possible so she can do IVF. And again, this is the different types of patients that you have to manage. So in the first patient who had a very reduced AMH, you could see over here that the cyst itself, the mere presence of an endometrioma, is associated with decreased ovarian reserve as measured by anti-Mullerian hormone in this study, which looked at bilateral endometriomas, unilateral endometriosis, and none. And you see, as per rate age adjusted, it's much lower in the bilateral endometriomas. And this is because the cyst themselves, which very fibrotic layer, interface with the cortex, as you see here, different from a cystadenoma. These types of cysts have a tremendous amount of inflammation, and inflammation is what causes oftentimes the decreased anti-Mullerian hormone or ovarian reserve. In this group of studies that was published, these granulosa cells from patients with endometriosis are characterized by increased apoptosis. If the granulosa cells die due to oxidative stress, then what you do is you have a situation that we typically see in patients that are undergoing chemotherapy, which is the potential for burnout, meaning that you activate a lot of primordial follicles, and these primordial follicles then will activate tremendously, and you're overactivating these, and therefore you have this process called burnout. And the reason is, as you kill the granulosa cells, anti-Mullerian hormone goes down, and this anti-Mullerian hormone then has a role in the downward anti-Mullerian hormone in enhancing recruitment and then atresia. And in fact, active research is in the anti-Mullerian hormone synthetically made. You can actually give to patients, perhaps as a potential. Anyway, the point of this is that these patients have decreased ovarian reserve to start with. Now, if you remove the cyst, according to this nice study by Virgilini's group, if you look at this big group, what they published was the number needed to treat is 4, meaning every time you do 4 patients with endometriomas, 1 will get pregnant. And because the preoperative diagnosis is clear, this means that with these patients, we can achieve a high pregnancy rate from surgery. There is a caveat to that, and we'll talk about it in a moment, which means is that you have to look at any other disease that the patient may have. This is truly only for an isolated endometrioma. And then the second thing that they talk about is the cyst excision reduces the rate of recurrence, including symptom recurrence, and maybe increased spontaneous pregnancy rates in the initial studies. Now, in the initial studies, we have to tell you that there are limitations, because if you look at the recurrence rate of cystectomy versus laser ablation, for example, really the recurrence at 12 months is lower with cystectomy, but if you follow the patient with time, it really is about the same. So therefore, Just remember that cystectomy may not be the answer to all patients, especially in patients with a decreased anti-Mullerian hormone, as reflective of lower ovarian reserve. And in fact, this study by Candiani, they looked at recurrence, and it was recorded to be 63.3% with cystectomy and 4.9% for patients managed for carbon dioxide laser. In fact, the only independent factor for recurrence was a large endometrioma, more than 5 centimeters, and discontinuation of hormonal therapy if your patient does not want to have a pregnancy. So we should not discount that perhaps like cystectomy is not the only approach. So why is cystectomy often associated with decreased ovarian reserve? Well, the first thing is the pathophysiology of an endometrioma. It means that the cyst itself, as it invaginates, is fused with the cortex. And as you see on the right side of the screen, this is the fibrotic layer, active area of research of what to do with this. And then you see the adhesions to the cortex. If you pull too hard, half the ovary can come with it. Not to mention the fact that people get confused with a very large cyst with the glistening area over here of the fibrosis versus the actual ovary cortex itself. So this is a study that we did, and we compared endometrioma cystectomy just with treating pelvic endometriosis without any endometrioma and just doing a diagnostic test. And what we see is that in patients that had cystectomy, the anti-Mullerian hormone dropped as compared to those that had just excision of endometriosis. So there's no question that it drops. The fascinating thing is that 6 months it has a tendency to recover, and what the question is, why does it even recover? Some people think it's because you've removed the inflammation. Others people feel that removing the inflammation stops this burnout concept. That is, the granulosa cells survive, they produce anti-Mullerian hormone, and there's no activation, perhaps. So what's important when you start these cases is to observe the tubes, to observe what other pathology, because removing the endometrioma does depend on the health of the tube as well as the ovary. And we use it just an observation, but there is an index called the Endometriosis Fertility Index that can be used to quantify this. So again, this is a normal right ovary and tube, and so a unilateral endometrioma, some adhesions, but the tube itself is normal. Now, typically, this is what happens. It ruptures, and then you start to peel the endometrioma. And again, the endometrioma is at the base, oftentimes, of the mesovarium where the blood vessels are, which means that there's an increased probability of bleeding as you remove the endometrioma towards the mesovarium. So the question is, what can you do once you do this to decrease bleeding? First, I also have to tell you that when you're doing recurrent endometrioma, not only do you have this fibrotic layer, but you also have adhesions to the cortex. Again, looking how close the cortex is to the actual endometrioma. So again, as you pull, you have to be very careful. Now, some people use vasopressin, which I know is not available in Europe, but in many countries it is. And there's some loose evidence to say when you inject it in the subcortical area, it may decrease bleeding. Now, there are equivalent studies showing that compared to saline, it does reduce the electrosurgery and tissue damage, while other studies shows that there is no difference. I use this a lot, which is a hemostatic agent. This happens to be FlowSeal, but there are many in the market. This is what I use once I've done the cystectomy. Rather than using excessive electrosurgery, I put this in and then I go to work on the other side or somewhere else. You could use a 3-stage operation that was pioneered by Jacques Donnet, where you drain it, put the patient on antagonist to decrease the perfusion of the ovary, which is what it does, and then you can use laser vaporization. However, there is a high recurrence with this, even though the AMH level has not gone down as much. Other things that you could use for very small endometriomas, you could use plasma energy, as you see here, very low depth of penetration, and you will not injure the cortex as much. Now, if you're using bipolar electrosurgery, just remember the penetration on the area is not deep, but deeper than the actual capsule of the cyst, which is only about 3 millimeters. So deep coagulation may destroy follicles. And for this reason, as you see in the 3 panels of what you should use, according to the studies, bipolar coagulation did more harm than suturing, which is right here, and bipolar desiccation versus suture versus hemostatic saline. Suturing is the best mechanism, followed by hemostatic agent, and the one that causes the most damage is electrosurgery. So again, techniques for decreasing the damage. Now, hemostatic sealant, this is published, sealant versus electrosurgery showed equivalent effectiveness in achieving hemostasis, so you can use the hemostatic sealant. In cases of bilateral cystectomy, the hemostatic sealant group exhibited less AMH levels, less decline. So again, something to consider. If you are doing the endometrioma surgery solely for, and then the patient's going to go on for IVF, there is no clinical advantage at all to removing the endometrioma. So I would not remove it. There are only 2 times that I would go in, and then if the patient makes a priority to treat the pain, or if the patient has very large endometriomas, as you saw on the case presentation. So if you're just saying, if the patient is sent to me for a 4-centimeter endometrioma, nope, and then I tell her you should do IVF. Does the fact that when you're looking at this, the question really is sorry about that. The question really is over here, a reduction in the response to ovarian stimulation can be detected if you have a larger than 4 centimeters. So it is true that a 5-centimeter endometrioma will have a decreased response. But again, it doesn't mean that you can't do it. But there does come a time where the size impedes all of being able to access any of the follicles. And then you're operating because of the size. Okay, if you are going to do this type of surgery, we always have to consider fertility preservation. And remember, fertility preservation is a very big topic. This one here, and typically it's egg freezing. The fascinating thing about egg freezing is you have to understand what the success rate is. So in Anna Cobo's study, they freezed eggs in 1,000 women, and about 46% returned. But of these 485, 218 patients failed to become pregnant after using all their oocytes. So just remember that half come back and half will exhaust all their eggs. And why is that? Well, first, if you've operated on the patient, the number of eggs you get is far less. Okay, so, and if they're young, if they're older, in fact, the number of eggs and pregnancy rates are about the same because older women age masks the effect of surgery. So surgery will definitely give you fewer eggs and potentially less cumulative pregnancy rate because you have fewer eggs. So if you look at cumulative pregnancy rates in women with endometriosis, and if you want to freeze the eggs and you want to have a 70% chance of pregnancy, you need 15 eggs. If you do 15 eggs in women over 35, you only get 50%. What does this mean? It means that patients actually exhaust their eggs before getting pregnant because you need a large number. So if you're going to do IVF in these patients, and this is why we typically do it before surgery, you're going to get fewer eggs, and therefore you need to do more IVF cycles. But a lot of patients oftentimes won't do 2 or 3 cycles. So you have fewer eggs, and then when they try to use them, they exhaust them before getting pregnant. Okay, so we're going to cover now the rest of the field of deep endometriosis, bladder, ureter, rectum, and rectum over here. And what's important, so if you see in this particular patient, she has a lesion Over here, this is a 36-year-old woman, 2-year history of infertility, dysmenorrhea, and as you see, she has a 4-centimeter cystic endometrioma or cystic endometrium center on top of the bladder, anterior myometrium. The patient came to see me and she said, like, what should I do before do we do surgery immediately, or do we postpone and do IVF first, because she was interested in fertility? Right, so what's important here is to look, when you have deep endometriosis, is really not necessarily to look here. You're looking at the tubes and ovaries from a fertility point of view. So in this patient, see, her tubes and ovaries are pretty normal. So me doing this surgery here will have a good prognosis because she already has normal tubes and ovaries. Now you say, what is the value of doing this? Let's say this patient doesn't want IVF. What is the value? Well, it turns out that the lesion in the cul-de-sac here does have an effect on implantation. So even though they may not be contiguous, there is no question that there is an effect. Now, this is again another lesion of the rectum. This is the cervix, and you see a nice rectovaginal septum coming up. So therefore, this is the cervix. We put contrast in the vagina when we do this, and therefore we can see the vagina. But over here, the septum is maintained so we can get underneath the lesion. So you can see I can get underneath this lesion. And there are different algorithms for when you operate. The point of this is to use either resection versus shaving versus nodule resection, which I'm not going to go really into in detail, other than to show you that you can do the nodule very easily. This is the patient's left ureter, or you can you remove the nodule, or you can do a disc resection, as you see here, or you can do a segmental resection. The point of all this is to look at the pregnancies rates. Now, the main confounding variable when people report the pregnancy rate in patients that have had advanced surgery for deeply infiltrating disease is they include patients that were never infertile. They just simply include the entire population, and then they say, oh, I have a 40% pregnancy rate, 50%. Now, in this study, again, by the Italian group, they only took infertile women and then looked at the pregnancy rates in patients that had rectovaginal endometriosis. And you see the pregnancy rate is actually between 20 and 30% because they're infertile to start with, which is what the purpose is. Patient is infertile and then presents with endo. Then what you see is that the pregnancy rate is not as good as people that are unknown fertility or fertile to start with. And you see the follow-up is variable to achieve these pregnancies. Now, the reason why you decide what to do with these patients is based on the endometriosis fertility index, which is an index which is the higher number means a good pregnancy rate. But what you look at is the least function score. The rest of it is pretty, like how long you've been, how old you are, and years of infertility, etc. The most important thing is the least function score, which means you look at the ovary, you look at the fibri and the tube, and you look at the quality of this, and that will determine at the end of surgery if they're going to get pregnant spontaneously or not. It also helps you to decide how aggressive you are in removing the cyst if she has one. Now, if you look at this, the upper panel, endometriosis, this patient has adhesions to the fundus here, adnexal mass. After I've resected all this, I assure you the tube and ovary will not rate the highest. The lower panel, you see the ovaries and tubes are normal to start with. So when you resect this lesion, they will have a great least function score, a high score here, and will get pregnant. Now remember, when you look at this, you can do the score, or anybody who's has skill knows that the top one is bad and the lower one's not so good. Top one is bad and the lower one is good, so you can get this. Now, if you look at the validation of this index, it is very highly validated with high pregnancy rates if at the end of surgery your tubes and ovaries are normal. This is a study by Horst Roman, and what he did is he had 36 patients, bad endo, and what he looked at 36, he allowed 20 to get spontaneously pregnant, and he allowed the rest of them, 16, to go through IVF. And even if you ignore the middle part, what he did is he used the endometriosis fertility index by looking at the patient. The ones he thought had a good tubes and ovaries, they got pregnant. The ones he thought that did not have good tubes and ovaries, he sent them on to IVF. And you see over here, the fertility rate is similar. This is a Finnish study. Again, patients diagnosed with rectovaginal endometriosis, treated operatively or treated conservatively. As you see, conservative versus operate. Again, the curves are superimposed, always with the idea that the tubes and ovaries are normal. So therefore, the good news is if you're treating this patient for pain, they have a good pregnancy rate. Okay, so one of the things is, does endometriosis cause any egg problem or decrease implantation? Well, this is a study by this group, and what they found was if you have frozen embryos, whether you have endo or not, the pregnancy rate is the same as long as you put the patient on estrogen and progesterone for the transfer. This is simply last few slides. If you look at the complication rate, because the patient wants to know this, and again, this is British Journal of OBGYN, and if they have rectal surgery or no rectal surgery, it's 13%. But in patients with that 4.6% have this major type of complication, and basically is if you have rectal surgery. If you have rectal surgery, you can have this complication. The complication is low if you don't. So the patient should be told this. And again, this is again from Horace Roman's group. This is actually my patient, the patient with multitude of endometriosis. The recurrence is there at 15%. And again, if you look at over here, the highest complications are those where you're doing repeat surgery, and patient again should be told. Now, this is a qualitative study, and what they found that if patients have a lot of pain, so you have to understand what you're doing this for. Treating pain, preparing the patient for IVF. Is the IVF doctor comfortable doing the egg retrieval? These are all things that are important. So we can resume this. This patient has a low anti-Mullerian hormone. Her ovaries cysts are not that bad. They're 5 and 3. I would encourage this patient to do IVF first if we can. Oftentimes we put them on a GnRH antagonist, and then they can go ahead and do stimulation. This one here is the same thing. She actually got pregnant, and as soon as she's done, she'll come back to me for management. And so this concludes. This is just to show you what my job is. International operations. This is Cleveland Clinic London. This is Cleveland Clinic where I am. This is Cleveland Clinic Florida. This is Cleveland Clinic Abu Dhabi, Cleveland Clinic Toronto, Cleveland Clinic Las Vegas, and Cleveland Clinic in Vietnam. So I'm going to conclude, and I'll start sharing my screen if I can find where it is. Let's see. I'm trying to find, okay. Let me just see if I can finish this. And
perfect.
okay, let me see here. Okay, great.
Great. So thank you very much, Tommaso, for this comprehensive and very much insightful presentation. And obviously, as we said, we all learned from you in a way or another, and we'll continue to learn. So thank you very much. We have some questions here, and we want from you, obviously, your opinion, and I will try to be telegraphic because I know that you don't have a lot of time. So first question, sclerotherapy, alcohol sclerotherapy. Do you suggest it? Do you recommend it? Do you do it?
Right. So I personally do not do it, but I did review a couple of the studies when I was editor of JMIG, including the one by Horace Roman. First of all, if you do there are two ways of doing it: transvaginally, ultrasound, and then stick it, or laparoscopic. If you have multiple cysts for the patients, it's very difficult to do because then you put a couple of holes in as you're draining the cysts, and then the alcohol will leak. If you just stick the alcohol in and then wait amount of time and then take it out, there is no question that you can treat the endometrioma. The interesting thing is, in the study by Horace Roman, the anti-Mullerian hormone, which is a reflection of ovarian reserve, went down as well. Okay, so if you're looking to see the purpose of the sclerotherapy versus cystectomy, or even what I use sometimes is just ablate the inside, depending on what the patient discussed, you still have reduction of anti-Mullerian hormone. So there's nothing wrong with the technique. Just remember though, when you're operating and you have big endometriomas, as you lift them up and they rupture, if you put a big hole in the endometrioma, it's very difficult to then put alcohol in and have it that way.
Perfect. The other question is about, and maybe I understood well, I hope, is about endometriosis itself. It impacts the ovaries. It impacts the ovarian reserve, oxidative stress, etc., etc. So the question from the colleague was, would surgery in any form or shape for ovarian endometriomas improve ovarian reserve AMH?
Yes.
This is the question.
This is an explanation of an observation. So I don't have proof, but someone wants to do the study. The AMH goes down, is low, even if you don't operate. When I remove the cyst, the AMH seems to recover. My explanation is that there's less oxidative stress, less inflammation, and that helps it to recover. However, there's no question that your surgery damaged the ovary. What it is that, remember, what produces anti-Mullerian hormone are granulosa cells. Once you reach an equilibrium, again, between the primordial follicles and the growing follicles, because remember, the small preantral follicles of the granulosa cells, once you reach an equilibrium, the AMH will come back to normal because you have the same number of cells, of granulosa cells. The primordial follicles, remember, do not produce anti-Mullerian hormone. It's the small preantral follicles. So yes, the AMH does recover because of decreased inflammation, but it doesn't mean your surgery is not there. What is the risk of freezing eggs in the context of growth of endometriosis due to hormone? None. There is no risk. It is easy to freeze eggs. The only problem is if the endometrioma size you can't get the needle around it, but the eggs are fine. In fact, remember, the eggs in these patients, it's mostly the quantity of the eggs which are reduced if you operate, or even if you don't operate, I guess. So it's just a question of, if when I tell the patients that they should, I want them to do the IVF before I operate.
Sure. And you stop us when you want to, Maj, because we have so many questions here, and I will go.
4 minutes.
Okay, good. Quick and telegraphic. There is a question about your opinion in interval ART, which means delayed cystectomy after oocyte retrieval and delayed embryo transfer to after cystectomy.
Right. So if they have frozen eggs or embryos, then basically after cystectomy, we do a program cycle. That's the reason why IVF works for frozen thought. So we freeze everyone's embryos in IVF in a patient with endometriosis. I freeze all the embryos. Then you do the surgery. Then you put them on estrogen and progesterone, and then you do the transfer. You can do it immediately because the estrogen and progesterone is what is the one that decreases the inflammation of the pelvis from the rest of the disease. So a program cycle gives you the same pregnancy rate in these patients. So you can go immediately to IVF after cystectomy if you wish, if the patient wishes. One more question.
Sure.
I have to go.
Pavel.
Yeah. Well, maybe we continue the question from probably a patient. Scheduled for first surgery, can I go for IVF first because married for 15 years without a child?
No. again, you have to talk to the patient. If the patient comes to see me and says, I have intractable pain, then I have to operate. Just remember, most of the pain is from the deep endo. But so therefore, I always try IVF. Remember, you freeze the eggs, freeze the embryos, depending on what the patient wants, and then you can manage the implantation. And the concept is the same. You have to figure out what the patient wants. But if fertility is the option, then IVF, in our programs here, we have 60% pregnancy rate within 2 months. I mean, the pregnancy rates now are very high. And more importantly, if the patient is not interested in immediate pregnancy, she needs to freeze enough. I showed you the slide. You need to freeze enough eggs to get a high probability of pregnancy. You're not going to do it from one cycle, maybe. And after surgery, the main limitation is the fact that they have a decreased ovarian reserve. And again, and although, so AMH is used, is a reflection of ovarian reserve. The only time it doesn't predict pregnancy,
Sure.
but it predicts how many eggs you will get from IVF. It also predicts the fact that you've damaged the ovary. There's no reason AMH goes down unless you remove granulosa cells. It's as simple as that. When I did the study and I removed endometriosis of the cul-de-sac, the AMH never budged. So just operating on endo does not decrease your AMH. You have to touch the ovary. If you touch the ovary, AMH goes down. So you've induced some damage to the ovary. It doesn't mean they can't get pregnant, but the AMH will tell you how many eggs you'll get. And the reality is that patients with all the studies, from mostly Anna Cobo, shows that you will get fewer eggs in patients you've operated on. So that's it. And
Perfect,
on that note,
Tommaso.
I got to run. I love all your questions.
Thank you very much.
I'm sure you can answer all of them.
We will try, but we would like just to thank you very much for being here with us, and we will try to remain for 5 minutes more to try to answer some more questions. And thanks again for joining us, Tommaso, and we really appreciate it. Thank you. Thank you very much.
Thank you very much. Yes.
Okay, guys, we still have some questions, and we're very happy to answer. Obviously not at the level of Tommaso Falcone, but we will do our best. So just to wrap up and to summarize here, I think if we can conclude from Tommaso's presentation is again and again and again, there is no one size fits all, and treatment should be personalized. Patients' objectives are extremely important, and for clinicians, it's very important to understand patients' objectives. We're not treating lesions. We're trying to treat patients and solve problems of the patients in this exact moment. Treating a patient with pain is different from treating a patient with fertility. Same lesion, same patient, different phase of her life. Management can be different. And care about ovaries and ovarian reserve and fertility preservation, etc., something that we have to bear in mind before operating. A patient that he has shown 24 years old, AMH 0.02 due to previous endometriosis surgery, is unfair. It's a bit of a problem, if that makes sense. So let's try to answer the questions here. As you can see that we have also Aline and we have Attila. And let's take 5 more minutes to discuss here. AMH is, Ahmed Al-Nagar is asking, AMH is mainly to predict ovarian response, ovarian stimulation, rather than correlating the spontaneous yes to conception's chance. So yes, this is exactly what Tommaso was saying. It does not reflect the chances of getting pregnant. It just shows your ovarian reserve. For bilateral endometrioma more than 5 centimeters, with a lot of pain and concern for fertility, was the best approach. Okay. Who would you like to answer, Ali, in this question? For a bilateral endometrioma more than 5 centimeters, a lot of pain, fertility, what's the best approach?
Again, we don't have enough data to conclude on the optimal approach. As you said, it has to be a tailored approach. So I would say we definitely need more information from the patient. How old is the patient? Any previous pregnancies? We need information from the partner. Maybe the safest way to go would be to do a medical freezing before going to surgery. And going to surgery, I think the indication is pain. As Tommaso was saying earlier, that's the main indication to do any surgical attempt.
Well,
Okay.
and if I may add, I think this
Please, Pavel.
in this case, when you have a like 5 centimeters endometrioma, which is symptomatic, I would say, in respect of pain, I think if it's unilateral or even bilateral, but not a multiple, I think sclerotherapy, even through vaginal route, could be the option here.
Sure. So here the point is, we are not against surgery, and we have to make it very, very clear. We are just trying to tailor approaches to every patient. So this patient, our role is to give as much options as we can, as much information as we can, and we help the patient to make her informed choice. A patient with bilateral endometrioma, 5 centimeters, if she's 45 years old and she wants a child, this is an issue. If she's 24, this is another issue. As Aline was saying, if she has been operated 2-3 times, this is an issue. If she hasn't been operated before, this is another issue. Male factor infertility, she wants spontaneous pregnancy. We need to globally think about the patient, understand her objectives, and give her all the options that fit her. Then, if that's okay, we try to tailor a treatment plan for every patient, if that makes sense. But what we don't want, or what is not, let's say, we try to avoid, or with our awareness, with our EndoEngage, with everything we try to avoid, is that we are not treating lesions. It's not that we find a cyst, we think about 5 centimeter cyst and we remove a cyst. It's a bit different. So here we have some other questions about, several cases where endometriosis growth increased dramatically after failed IVF rounds. So the other, if we can rephrase this question, Mel, is it that endometriosis treating patient, not lesions? Yes, absolutely, Amy. Thank you for this comment. We are treating patients. We're not treating lesions at all. And that's what we aim at. We're treating, it's not a lesion-oriented approach. It's a patient, a problem-oriented approach. So the question here about the increasing endometriosis with IVF. So any input, Pavel, about this, or any comment you want to add here about IVF increasing size and of lesions or making endometriosis worse? Is there a strong evidence in the literature to support this?
Well, I am not quite familiar if we have a really robust data, but this is what we all faced when we have a patient after many attempts to IVF rounds, that the lesions exaggerating in growth and also endometriomas. And this is quite easy to probably to show up and to explain, because of estradiol feeding of those lesions. And this is well, it's maybe not quite well evidence based, but we face this situation.
Okay, Aline, we have another question here, and
Mohammed,
about,
if I may add to the previous
Please.
question, I think one of the few situations when IVF can cause problems is for lesions localized on the sigmoid colon who haven't caused a major stenosis yet. And through the stimulation, they can grow in size and cause a stenosis. I had one case when I used to be in Hamburg, and the patient, after the IVF, unfortunately, had to get a transversostoma. I think this is one of the few situations. Otherwise, as Tommaso was saying, IVF is not making endometriosis worse.
Yes, so if we have to conclude in this point, theoretically, stimulation would increase the risk of growth of making endometriosis. Theoretically, yes. Is this what we see in all the patients? The answer is no. Is this something that we frequently see in the patients? The answer is not. You're mentioning one case that you have seen somewhere, and we don't know among how many hundreds or thousands of cases that you have seen all through your career. So what we are saying is, can this happen, yes or no? The answer is yes. Is it a common occurrence, yes or no? The answer is no. Is it something that would stop us from inviting patients to do IVF if their main objective is fertility and if they have endometriosis, etc., and balancing risks and benefits? The answer is no. It can happen, yes. We counsel our patients that this is a possibility and it can happen. We are about to conclude, so I would like to answer the last question here. Those of
Mohammed, but maybe
yes, please,
just one more comment. If we stay on the fear of hormonal treatment and stimulation, there was somewhere in the list also the question about hormonal treatment for deep endo and IVF for women with strong family breast cancer history. And is it okay to put those women on a severe stimulation protocol? And we have to bear in mind that speaking about strong family ancestry of breast cancer, most of those cancers are basal type, so they are hormonal non-responsive. That's why we shouldn't be as sure that the hormonal treatment can really interfere with the risk of breast cancer. So this is the answer for this question. So again, is this strong family breast history contraindication for hormonal stimulation? I don't think so.
Again, so we have still some comments and the questions. We can still, yes, we are very happy to go through them. So here, the point about the common in literature, and thank you very much, Amy, for this comment. Common in literature and statistics, and thank you for raising this point. That's very important. So common in literature and statistics, I totally agree with you. Common in reality is different because publication, there are some colleagues who see patients who don't publish them. And there are some colleagues who publish and it's not similarly equal what we publish in the literature and what we read and the statistics and the numbers than in reality. And this is why when we say to our patients, and this is what my colleague Alin was saying, he has seen a case and it is the reality. I have seen some cases, yes, but again, surgery is very important. We do surgery, we remove endometriosis, we excise endometriosis, and this is how we think about it, and our philosophy about it. But again, in some patients that are having endometriosis, their main objective in this exact moment is to have a pregnancy, and maybe they don't have a lot of pain, maybe their endometriosis is not too severe, not impacting their organs, etc., etc. What we do is we counsel our patients all options. We give them all the information. We help them to make informed choice. And if the patient's choice is, in this exact moment of my life, I don't want to undergo surgery after surgery, and my main objective now is to have a pregnancy and I want to have it with IVF, this is where we say, okay, actually, there is a possibility that IVF might worsen your situation, but the reality is this is not something very common. Here, we are so sorry to know about, yes, to read this comment about repeat surgeries and menopause and pre-large endometriomas. We're so sorry for this. And unfortunately, we haven't covered this topic, but we have upcoming webinars when we will be speaking about different types and forms of endometriosis also affecting different phases of the woman's reproductive life. The question about 15 centimeter endometrioma sclerotherapy, I don't think that sclerotherapy would be a good option for a patient with a 15 centimeter endometrioma. I don't do it. I'm not very much into it, but even my colleagues who do it, and there is no strong evidence to support it, but in my opinion, 15 centimeters is beyond the limit of doing alcohol sclerotherapy. Pavel and Alin, what do you think?
Definitely, that requires a substantial load of alcohol you have to put in.
Yes,
and
2 bottles.
Well, and of course, this is the fact is that after sclerotherapy, we often observe a kind of a debris formating in the former cyst, and this could probably not be as efficient as we'd like to obtain by sclerotherapy by such a large cyst. Aline, what's your opinion?
I agree with both of you guys. What I would add is when we're talking about a 15-centimeter lesion, we also need to think about what kind of cyst this is. Are we talking about really an endometriosis cyst? It's very important to exclude a malignant cyst in such cases, anything that's above 10 centimeters.
Great. So I think we have covered most of the comments. Apologies if we missed any. And we will upload, as my colleagues and the lovely, fantastic young team who is also helping us with the EndoEngage program. I would like to thank you all. Thank all our young EEL fellows and colleagues who are helping us to raise awareness and to engage all our colleagues in endometriosis management. Thanks to the patients and to the patient advocacy groups. We are running so many enthusiastic projects only by the help of you and your support. So I would like to thank you. I'd like to thank also my colleagues who are helping us with the EndoEngage. We will upload the videos as you have read on the YouTube channel and on the website of the EEL. Again, for my colleagues who are here with us, there are a lot of interesting projects. We are launching very recently, very soon, a grant for hands-on cadaveric training. Please stay tuned and observe our announcements on social media. This is a grant for 10 to 12 young consultants to come and do stay with us, full immersion for hands-on training on for endometriosis surgery, and also so many other projects. So please stay tuned. And did I forget anything, Ali? Yes, a lot of master classes, robotic master classes, and also diagnostics, ultrasound, etc. So the next webinar will be on Tuesday, and this will be the second Tuesday of May. So please join us. A very interesting topic, very experienced speaker, and we will be announcing it very, very soon. So thank you very much. Pavel, would you like to add? And Aline, please. Did I forget anything?
Nothing to add. Thank you very much, Mohammed.